may not always be able to be in the ceremonies, but being in any kind of community events, whether they have walk runs or whether they have something else going on, even the powwows, that would be very important to be seen by the community. And the more you do that, the more that you're going to be seen as part of the community.
Thank you. That's helpful. In talking with the focus groups that we held several years ago and since then, it seemed very apparent to me that many of the adaptations that we were looking at making to the addendum here fit very nicely with motivational techniques and motivational enhancement approaches, strengths-based approaches. There may be differences in those formal models of, like, say, motivational interviewing and specific cultural kinds of approaches to clinical supervision. But in general, the spirit of motivation and strengths-based approaches was very present in the way that Native Americans expressed themselves. So this was I thought, one very clear correlation between motivational approaches and Native American culture. Now, I included a link here to a motivational interviewing manual that was developed not by the ATTC, not by the National American and Alaska Native ATTC, but by another group, and included the link here just so you could review it and see what you think. European models of clinical supervision are often perceived as being more confrontational, more direct in nature, and sometimes those models conflict with Native American forms of communication and teaching styles.
I think, sorry, Bob. One of the things about motivational interviewing, I think that makes it so, I guess, much better with Native Americans is it seems more of like just a discussion. When motivational interviewing was being made, he had actually been working with Native Americans before that, allowing him to develop this while he was there. He's seen how doing certain things and the way he spoke to them would get more information from the clients and the community members during that time.
Thanks, Sean. Several things stood out in this foundational area when we were talking with Native American professionals. The competencies are listed in tab 21A, and we just pulled out, I think, some of the ones that stood out as in need of special consideration. Understanding the multiple roles of the clinical supervisor, and you see them all listed here. I don't have to read them. The last one, the ability to articulate one's model of supervision, I think is important in the sense that it helps you as a clinical supervisor present the same way or in a similar way to whoever you're supervising, so there's some consistency there. And you're able to describe why you provide that particular model of supervision. It just adds some legitimacy, I think, to you as a professional to say this is the model of supervision I adhere to, and this is why. And gives the supervisee some clarity too on what to expect and how you interact with them.
Yes, when I had started in behavioral health, I had started in a substance abuse agency, and I think I was very lucky to have the people working with me that I did. I had the different theories and different things like that in college, but they were able to help me put it all together and how to utilize these different things. I mean, what really helped me was actually being able to have a supervisor sitting there with me while I'm doing this, whether it's my first assessment or my first notes or doing the first diagnosis or anything like that. recommendation for treatment. They were able to sit there and really help me with that, because sometimes even just knowing how to write a note or a recommendation properly can be very important, because it's like when you're going into any kind of thing like that, all those can be taken into court. So you always have to write like the judge is going to see it.
Yeah, you don't want a judge reading something that you intended to be funny.
Very true.
Try not to be funny. All right. So I'm going to let Sean, I think, cover this slide. It's an important aspect of what we were trying to do here.
I know with the storytelling, it can be very helpful, because sometimes it's like long ago, I remember the first time I ever went to see a medicine man, or before when I spoke to different elders. It's like I'd come to them with a problem, but they never really came out and just told me. They always told me a story. And I was like, why don't they ever give me the right answers? So I'd ask somebody else, and they really told me it's part of this learning process is to find your own way. And they're not always going to just come out and give you the answer. Just like in the counseling profession, they can't always just come out there and give you the answer. You have to be willing to make your own decisions and to walk your own path and make the decisions that you're going to. It's like metaphors, for example. I mean, for one thing, the way that I was taught is like a tree, for instance. Every leaf on the tree represents one of our hairs, or our hairs is like their leaves. The branches are like our arms. The roots, in a way, are like our legs, but also it's like we have these invisible roots that go into the ground, and also invisible roots to our family, mothers and grandparents and so on. So it really helps, and some of these teachings can be very interesting. They help you to grow further and understand that the importance of knowing and realizing that we're all related, and that doesn't mean just people, also with nature.
And Sean, I think it's important to mention here that for non-native professionals working with native communities, the storytelling is a skill that would have to be substantially developed and mentored before you start using this sort of approach. Is that correct?
Oh, yes. For one thing, you'd have to know each tribe, the tribe you're working with, because certain things might be taboo to one but not to the other. And depending on whether they're assimilated or traditional, bicultural, if you're even going to be allowed to do that.
Thank you. Move on to foundational area 2, leadership. Again, this is the way the TAP 21A is structured, so we're just following that guideline. The difference we found, and again, Sean can always correct me on any of this, but the difference that we found with Native American communities is that the clinical supervisor doesn't only represent the organization, they represent the larger interests of the tribal community. So there's an additional layer of responsibility, I think, and a more complicated role in a sense, because you're not just promoting the organization's mission, vision, and philosophy, but you're adhering to a larger set of beliefs and values and interests, I think, for the community. Is that a fairly accurate description, Sean, of one of the key areas that we focused on for this particular foundation area.
Yes, this is very important, especially like within a tribe. If you're working for a tribe, it's even more so important because usually the leadership in a tribe, it doesn't mean they're the actual leaders. It's like they're more of like spokespersons for the tribe. So like long ago, they would kind of come to an consensus of what the tribe had wanted, but also at the same time, in their expertise, they would be able to say, well, this might be a little bit better. But within native communities, what happens is that some of the workers might come in there and maybe they're coming from a culture that they say, no, you have to do what I say. But at the same time, it's like the tribe itself owns all these entities within the tribe. It's not like one member of the tribe owns just something. It's like it's owned as a community. So in the same way, they might say, well, you're working for us. It's like, and so it becomes a little bit different. Culture-wise, anyway.
Thanks, Sean. We also asked our focus groups that we met with several years ago what they would list as their primary, and again, this is sort of general, but primary, the values and beliefs that were most important to leadership. And these aren't weighted or arranged in any particular order. This was just a list of things that the tribal representatives offered as some of the key values that were important to leadership. So you can see them here. Again, I think many of these values align nicely with motivational approaches and strengths-based approaches.
Yes. Okay. No, go ahead, Bob.
No, I'm done.
Oh, okay. Okay. It's like some of these, like humility is very important within communities, especially like in leadership, because it's like they might not always know everything, but being able to listen to certain people's. Because long ago, it's like there wasn't always one like a chief. Sometimes these chiefs might go by seasons or what is happening within their tribe. So if they're going to war or anything like that, there's a certain one in charge. If the growing season, there's a certain one in charge. And they don't always show it, but you'll see like a leadership of men around a circle, but right behind them, almost beside them, is their own spouses. So they're able to take these information from the female side and the male side and put that in there, and also being honest, cooperating with everybody. And you'll see like long ago, it's like very traditional people, they won't always just come to an answer right away. They think about that for a while, and this helps to avoid conflict. You'll see many tribes, they'll be wanting to give gifts. So this kind of becomes a little difficult too, because you also have to watch whether you're being respectful or not, because it talks about generosity and spirituality, and remember that spirituality is part of every one of these things. But it's like gift giving can be a little bit difficult in our line of work when we come to our ethical responsibilities, but also to the tribe and the people.
Thanks, Sean. So foundation area. Looks like we should have said foundation area 3, unless I'm wrong here, but it's supervisory alliance would be the next foundation area. And it includes these things under these bullet points. One of the points we wanted to highlight here was that avoiding dual relationships was viewed as a key foundational component of foundational area 3. And again, I'll just use my example of working in Hawaii, but it was an island, obviously. So you had a close knit kind of um, community, and people knew each other. They were related to each other. They had relationships. That is, the professionals working in addiction treatment had oftentimes relationships with the clients that came in. There was no way to avoid that. And the intimate nature of these communities means it's very challenging sometimes, I think, to avoid these dual relationships. There sometimes is literally no one else you can refer the client to other than, maybe yourself if you're the only provider in that particular area. So I'll let Sean again comment on this, but I think that's an important consideration. And it comes up when Sean and I do trainings around the country in test prep for the licensing or credentialing exam, that this issue comes up regularly, and people say, well, there's no way to avoid this conflict sometimes, or this dual relationship scenario. And we do have suggestions for how to manage that, but I'll let Sean comment first.
Yeah, that's very good, Bob. I remember that we had been talking to somebody about a sweat lodge one time, and there was one of the workers. They also ran a sweat lodge, so they're one of the traditional people within the tribe, and they were wanting to have these clients go to their house to this sweat lodge because there wasn't always somewhere else to go. Well, in a way, that can be difficult because you're actually bringing clientele to your home, so it kind of crosses into dual relationships and ethical boundaries. But what may have been more appropriate, and that's what we suggested, was for them to move their sweat lodge away from their home, somewhere where it's more of a community type area, and that will allow some of that. And then also it's like having it more open to everybody, but your clientele would know that maybe they should go, and that it's open to more people than just them. So then when you're going in there, it's like remembering that you always let your client say hi to you first or something like that, and remembering not to mention anything about treatment or anything.
Thanks, Sean. Foundation Area 4 has to do with critical thinking. We included this slide to point out some of the communication style differences. It connected with critical thought, but the idea here was to focus, for the limitations of this presentation and the time, to focus on communication style differences. These again were taken from another source, but the focus groups that we worked with seem to agree that these were, in general, significant differences between Western or European style communication and Native American communication styles. So you can see from this list, there were a couple that surprised me or that I didn't know going into this project. Say the light handshake was a new one for me. So there's more differences than this, and they're going to change based on individual communities. But this was meant to sort of highlight some of the differences that maybe we can be aware of. That is, those of us who are not Native American and maybe work with Native American communities can at least be aware of and build upon this list even more specific or tailor it to individual communities.
Yes, just kind of different. I don't know if, because if you think about it, if you look at the Western approach, in a way it looks more critical. In the Native American community styles, it's more thinking. It's like silence, of course. They're thinking about everything that's being said, so they can take that in and try to help a little bit better by learning through that and getting the big picture. Eye contact, of course, it can be a sign of aggression. The light handshake, the only thing I would say about that, if to go by them, if they start to get harder and you you really got to pay attention to that. Then you know how far you can go with that, because at the same time, if somebody would come in there and give you a really hard handshake, it's like you kind of meet with the same kind of force, but remembering to do it in not an aggressive way.
And I think the themes to point out here is that critical thought obviously happens in both cases here, but Native American communication styles tend to be more emotionally based as opposed to focusing on logic and decision making in the moment. I think sometimes, at least in my training, as I developed as a clinical supervisor, I felt like I had to have the answers right then and there. I had to be decisive, etc. And if what I'm hearing Sean say is that often Native Americans will not respond right away or not respond directly, but think more carefully about what's been said and respond in a way that incorporates emotion into the response. Is that kind of a summary?
Correct.
Okay. And Foundation Area 5, it's the last foundational area, organizational management and administration. These are just definitions based on TAP 21A of what management and administration mean in this case. And some differences in terms of how tribal communities or tribal leaders have to respond differently based on their governmental structure and laws. I'll let Sean explain this a little better.
Yes, this can be very difficult when working with the tribal council members and stuff like that, because sometimes they may want to see some of the things that's going on from either reports that they've seen or complaints or anything like that. But the biggest thing about that is that you need to remember that no matter what, you still have to follow your guidelines with ethics. So sometimes in asking or speaking to the tribal council who want to see certain things within about maybe certain peoples, because what happens is maybe a family member calls or something like that and says, we know this person's here, but they're saying they can't tell us that. So they may not understand the ethical codes that we have to follow. So allowing them to understand that will be helpful. But with the tribal council, I mean, even if they want to push further, you would let them know. It's like, if you were one of our clientele, would you want us to give your information out to others? And sometimes they'll say, well, no. And so that's the same kind of thing. We are trying to protect the clientele that we serve, and that is the guidelines we have to follow.
And we're moving right along primarily because of the time limitation here. So I want to start on the performance domains, the counselor development. I don't think this is a surprise to anyone, but one of the issues that we've certainly had emphasized to us is the workforce problems within tribal communities. That is the challenges faced by tribal communities to recruit and retain quote unquote qualified professionals to work in their facilities. I believe we'll talk a little more about that, but one of the key areas that the folks we talked to in focus groups said would be important is to really focus attention on entry-level staff to develop, provide a career ladder, and allow them to develop within the organization and assist them in becoming certified or licensed or whatever the requirements are for your state.
Hmm. Also, what might go along with this if you have new staff. It's like it wouldn't matter how high up they were. It's like they all would also have to remember to respect the culture that they are serving. So sometimes working with tribes, they'll have some kind of paper saying within their documents when they first get on is they will respect their culture. And sometimes it's kind of difficult if they don't understand that. So not only is there going to be trainings for newer staff for their own development, but also with non-native staff so they understand even just small things. I remember we had a worker, he's probably been there about a year, but they hadn't seen where or hadn't been taught about the community when somebody passes away within the community. And this person was walking around the office whistling. And finally, I went in there and said, could you please not whistle for the next couple days? In our way, we don't do that when somebody passes away. And they said, oh, I never knew that. I'm sorry. So, I mean, he would follow that. So there's different instances where certain things go on where sometimes it takes just a little bit more education about certain things.
Thanks, Sean. As I said, recruitment, retention, and leadership development are a primary concern. There are workforce shortages in general, but even more pronounced in Native American communities. Again, focus on entry-level staff. And I think what came out in these focus groups when developing this training was that counselor development should also include the intention to consider overall tribal health and well-being as a part of treatment. Not that other communities don't consider that as important, but I think given the addiction problems that exist and the difficulty recruiting qualified counselors and clinical supervisors within these communities, I think it's especially important in recruiting to emphasize that if you come here, you're not just coming here to be a counselor, you're coming here to benefit the community, to benefit the health and well-being of the community. Mm-hmm. I hope that makes sense, but
yes, and
providing.
Also,
go ahead, Sean.
Also, if any of you are aware of like the medicine wheel and how to work with that, for instance, like you have the 4 parts of the medicine wheel. One is more used for the physical, the emotional, the intellectual or mind, and then the spirit. So then also remembering that with the staff and remembering that with your clientele, that'll be helpful because sometimes in supervising non-native staff who work with Native Americans, you also have to be able to teach them these things as well so that they can incorporate some of that within the work duties and how they deal with their clients. It's like how to look at the whole person and not just certain aspects.
So clinical supervisors play a critical role in sort of developing this atmosphere or this culture of paying attention to these specific kinds of issues that are more specific to tribal communities. Mm-hmm. Some of the reasons that the focus group members came up with that lead to workforce problems include salary disparities and these things listed here. Again, as I mentioned before, Sean and I do travel around and do test prep trainings for Native communities to help counselors prepare for licensing and certification exams. This particular training on clinical supervision, the full training of 2 days, would also be, I think, an option for us to provide within these communities around the country to help build the workforce and help people move into positions of leadership with a good understanding of what's required and what's needed, not just from a cultural perspective, but what's really a foundation already in existence with TAP 21A and other kinds of formal clinical supervision documents. So we have an opportunity here to, I think, to improve the workforce through emphasizing some of the key requirements that any clinical supervisor would need to meet, but also to bring in this cultural layer of expertise that's also required, and help prepare the workforce, help build some momentum, some enthusiasm for current clinicians to want to move into that role. Not every good counselor makes a good supervisor, so the more we can do along the lines of developing skills for those that are a good match, I think we help improve the workforce. Mm-hmm. So career ladders are simply a way to build into your organization an opportunity for someone to move along those lines from maybe a direct care staff to a counselor to a clinical supervisor, etc., and to strongly recruit entry-level professionals with experiential and cultural knowledge. It's becoming increasingly important for college degrees to be a part of that mix. I think there's some room, especially with populations where workforce issues are so prevalent, that making a case for experiential knowledge in some of those cases might be a good avenue to go down. So just some ways to connect professionals with the community, again, clinical supervisors in particular. And we really wanted to stress the importance of the role of a leader, of a clinical supervisor, or someone in a leadership position within these organizations. In removing the stigma, and again, this goes back to working with the community, but to work with the community to better understand what addiction is, how it influences health and impacts health, and how it impacts the culture, the health of the culture. So the people that become clinical supervisors in these settings have an additional weight on their shoulders, an additional level of responsibility, I think, to ensure that the community's health is important, and the stigma attached to addiction is one of the barriers for people getting help. And to really get that message out there and communicate clearly within the community, and build that support for improving the health of the community. Professional and ethical standards. We've already sort of talked about how ethically, how it can be difficult to maintain certain boundaries within Native American communities, just because they're often tight-knit and people know each other. It's one of the bigger challenges, as Sean mentioned earlier, with anonymity as well. If someone comes to treatment, how do we ensure that they feel comfortable in knowing that we won't reveal information about them without the proper consents and the proper procedure in place? So it's just another, can be a real ethical dilemma if you have these relationships on the outside of the program and you have to manage them within. So, anything else about that, Sean?
I, 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 Well, I think this can be very difficult, and especially like within a tribe, because it's even like what some larger communities you might be able to get away by using um, like initials or birth date, but with such a small community where everybody really knows each other, sometimes those can be tied right to that person, because if you have, you know, a person who they might have been just a young child, maybe 12 years old or so, and you have the initials, but there's not that many girls within that age of us in that class, you can kind of figure out who it is. So that's something to consider when you're even talking about certain things in public or where you're around anybody in the public.
The performance domain 3 has to do with program development and quality assurance. And just quickly, you probably don't need this review, but mission statements are generally a description of who you are and what you do as an organization. Vision statements are more broad. They're meant to say, overall, what is it we want to achieve? And then strategic planning and organizational development often involve, especially I think in Native communities, involve community members. Whoops. We went ahead there for some reason. So as a clinical supervisor, obviously your job in part is to adhere to the mission statement of the organization, train clinicians, and bring them along in a direction that achieves the overall vision of the organization. And I think include them, that is, include those you supervise as well as the community in any strategic planning process. These are just some of the things that clinical supervisors, as I just sort of talked about, help to strengthen, build organizational culture, growth, and foster a culturally sensitive service delivery system. Always with the intention of creating a higher quality of care for the clients that we serve. Sorry about that. Performance domain 4, evaluation, performance evaluation. Quantitative and qualitative measures involve, I think, a combination of consistent measures that you can use for whoever you supervise. There has to be some indication, some metrics that looks at essential factors to counseling, and you're measuring those the same for everybody that you meet with. You know, and I'm just throwing this out. It could be something as simple as showing up on time for appointments or something of that nature, but it's very easily measured, very easily tracked. And qualitative measures might be more around the observation of clinical skills, the relationships that you see counselors forming with clients and with colleagues, and et cetera. So less tangible, less easily measured, but more in your observations. This is, you know, quality or an area of needed improvement for the clinician. Again, I'll let Sean speak about evaluations and how you evaluate some of these characteristics of a counselor, in keeping in mind some of the learning styles that we talked about, storytelling and metaphors and things of that nature, and motivations for working in the behavioral health field. Again, that kind of extends to improving community health and the health of the tribe. But I'll let Sean speak to that a little bit.
Well, one thing that comes to mind is that it's like looking within your organization. Sometimes you'll have people who have more experience or expertise in certain areas of the culture, or maybe they have their strengths working with the community, or something like that. You could utilize some of that, whether if they're a very good speaker, if they work good with the community, those might be ones that you could have them present to the community, reach out to the community. Those with strength around the culture can help more so with that. You'll have to remember that kind of like to use a strength-based model not only with your clientele but also with your supervisees.
That's a good point. Thanks, Sean. Fidelity measures are a way of measuring is something being implemented as it was intended. And I think as we develop clinical supervision strategies that are more tailored to any particular culture, we want to have a way of measuring whether or not our intention of improving client care and improving workforce issues is actually being achieved by making certain adjustments to approach, or by considering certain culturally specific kinds of approaches. So it doesn't sometimes matter if what we're doing is effective and we know it is, and by gosh, it's the best thing we could have done. If we can't show that in some way, if we can't evaluate it in such a way that we can prove that it's effective, and oftentimes it's not replicated or it's not sanctioned by those that fund us. So it's important, however we develop culturally specific kinds of programs, we need to have a way to show that they're either being effective or not being effective. If we don't do that, I think we're missing an opportunity here to really advance this effort, to really create culturally specific styles of supervision and culturally specific programs that are effective. If we can't show that it's effective, it's sort of pointless. I shouldn't say pointless, but it certainly doesn't help the cause if we don't do that. So I think it's up to the organization at some point, but maybe at some point SAMHSA or some other larger government or tribal body can establish criteria for measuring the effectiveness of these things.
Mm-hmm. Also, I do know that with some of the new outcome measures, what they're looking at different organizations or something, is not just looking at the workers themselves, but how the clientele are acting. I know where I used to work, what we used to do was to give all our clients evaluations before and after, and a lot of times we go by that, by maybe things to bring in, maybe things to adapt or something like that would assist more. And sometimes it's just the learning through that and watching your clientele, watching these people, how they react, whether it's benefiting them or they're hearing it at that time.
Yeah, that's a good point, Sean. And I think client surveys are a very good indication of whether or not we're actually doing what we intended to do, and if our approach is having the effect we intended it to have. So that's a good point. And the last performance domain is administration. It has to do with documentation, policies, and procedures, all of the things that an administrator is pretty familiar with. And again, it goes back to fidelity, and are we actually making a difference? Are we evaluating our efforts and our programs in a way that we can show it's being effective? And even if we find out it's not being effective, that's useful to know, so that you can adjust your approach or your program to move in a slightly different direction, in the hopes that you're making the proper adjustments to improve the quality of the care. Policies and procedures then would have to be written in such a way that it incorporated cultural differences and methods of clinical supervision that were in line with the cultural beliefs, systems, and values.
One thing I'm looking at this with the cultural differences is to distinguish the difference between like the disease concept, where some will say that the disease is an actual disease, much like cancer or diabetes. It's where some will see that these people are just kind of weak in the mind when that's not the case. So then viewing that, you can see a little bit more about the cultural differences. So then that's one thing with Bob had mentioned before about the test taking skills and stuff like that. We're helping to cross that cultural differences and help them to see these questions and see these different information from a different view.
Thanks, Sean. I think that's a big part of what we're doing with these test prep classes or these exam prep classes is to sometimes get into the language that's used or the method by which the question is asked. The way the question is asked can be confusing if you come at it from a different perspective. And we try and help to bridge that. I always half joke that my role is to be the middle-aged white guy that the exam was written for. So I may not be able to tell you how to translate what was asked, but I can at least tell you what it's asking, at least from my perspective. The exams themselves need to be culturally adapted, and we know that. And I think Sean has been doing a lot of work on that SPEP course in order to bring it in line more with culture rather than have us just restate Western notions about this and that that may or may not make sense to people. And the integration of evidence-based models with Native American cultural norms and communication styles is challenging in that we have to make this a systemic kind of change. We have to make the case again for how evidence-based approaches aren't necessarily Western-based approaches. They can be evidence-based and be culturally specific. They may look much different. Again, evaluation and all of those things are very critical in order to make that case. So I think that's what my intention was with this slide.
And a lot of the programs, the newer programs that they developed with other cultures, they have worked, but sometimes when they take it to native cultures, they don't. Those that have worked are those that didn't just come in there and said, this is what you need to do. The ones that worked went in there and they incorporated their information into what was already there culturally and what they were there as a program.
Thanks, Sean. I realize we kind of rushed through this a little bit, and this is just an overview again of a much longer 2-day training that we hope to pilot in the end of April at the Grandview Lodge in Nisswa. March and at the ATTC are partnering to provide this training. I wanted to leave a little time for questions before people have to leave us, and hopefully Sean or I can answer them.
Bob?
Yes.
Go ahead and start with the question. There's one person who's asking about a source that was referenced, and the link brought them to the University of Montana site. Let's see. It's resources on Native American communication styles. Can either of you remind us where you found the Native American communication styles PDF?
Well, I'd have to research that a little bit. This was probably something I found 5 years ago. So what I can do is look into that and get back to you or whoever I could send the information
Sure.
to.
How about you send it to me, and to the person who asked that question, I'm going to go ahead and put my email in the comments section, and if you send me your email, I'll make sure and get that information to you as soon as possible.
Talking about research style, what is best to use?
Native American communication styles was the is
Okay.
what you were talking about. So the next question says, as a clinical supervisor here on Rosebud, how can we utilize the performance plan evaluation to put staff on plans for improvement? And should there be a timeline for a plan of improvement?
Well, I would say yes, there should be a timeline. I think that's going to depend a little bit on your organization as to what you want to make that. Typically, performance improvement plans involve a pretty structured timeline and a pretty structured plan for what needs to improve and by when and et cetera. In my own experience, when I've done these, it's been meeting with first of all, laying out the areas that are in need of improvement, having a specific goal of when that person has achieved improvement enough to be considered competent in that area, and meet with them weekly for a period of weeks usually. Again, it depends on the organization, and monitor progress on those performance improvement goals that have been laid out. So I think I personally think it's best to have a pretty short timeline with being reasonable about how much time it might take for any particular goal to be achieved. If it's something very basic, like you're not coming to work on time or something of that nature, then it's probably a more immediate kind of time frame. If it's something along the lines of clinical skills that might require 2 or 3 months in order to begin to see improvement, then I think you make that judgment call. But it's going to depend a little bit. But I think it needs to be very structured, and every time you meet with them, there needs to be a discussion about, okay, what's changed, or has anything changed, and go from there.
Also, if they need some help with something, some kind of support.
Yeah, that's a good point, Sean. I mean, the whole point of a performance improvement plan is to assist the employee in developing whatever skills or whatever changes need to be made. So you really want to be, obviously, in the spirit of what we've talked about today. You obviously want to be a mentor. You want to be as encouraging as you can be to make sure that they have the support they need in order to make those changes. That's critical.
That's one thing to look at is you want to set them up to succeed, not fail.
Exactly.
We have another question about if you could talk a little more about the upcoming conference or training that you've mentioned previously.
Yes. March has an annual spring conference. This year it's being held at the Grandview Lodge in Nisswa, Minnesota on April 22nd and 23rd. And I believe registration for that conference will open this week. So if you go to the March website, you should see a link there, and it's MARRCH. If you go to the website, march.org, you can find a registration link. And again, I think that if that link isn't there right now, it should be later this week in order for you to register if you're interested. There's a discount for March members. Sean and I will both be presenting this training. Again, it's a pilot training, so we're going to be gathering input and making adjustments to the training based on the input. But we would welcome and really encourage people, if you can come, please do, because I think this is an opportunity, again, to really build some momentum towards culturally tailored clinical supervision and making systemic changes within this country around how services should be provided based on cultural differences. If you need any more information about that, my contact email here on this last slide, you can surely email me and I'll get back to you with whatever other information you might want. And there are CEUs available for cultural, I don't know what it's called with licensing, but it's the cultural requirements for CEUs, and I believe clinical supervision also is covered in terms of meeting those requirements. But I'll have to check on that a little bit with our events coordinator.
Thank you both so much. I'm going to go ahead and go through the kind of the ending few slides with just a few reminders. If you have any further questions, I have put my email address in the comment section. I'm sure Sean and Bob would also be happy to help with questions if
Can I just interrupt 1 second? I just noticed that my email address on the last slide is incorrect. It should be marrch.org.
Oh, sorry about that, Bob.
That's okay, but people's emails will bounce back.
Okay, I just put that in the comments as well.
Thank you.
Thank you, Bob. Thank you both so much. It was wonderful to hear from you. So if you have any questions, you can type them or you can send them to us. Please stay online as we close out the webinar so you can be redirected to our survey. Also, watch your email inbox for our follow-up, which will include a link to the recording of this webinar. Coming up in February, we will have a session on the DSM-5 led by Peter Nathan. And thank you again for your time and participating. We hope you have enjoyed the presentation and we look forward to hearing your feedback. So you will be bounced to a GIPRA meeting or a GIPRA forum as soon as I close out the meeting. Thank you all so much.